the very high risk for mental health problems among the parents, which also increase the risk for behavioral problems and other problems in the children. I have observed the fact that by kindergarten, many of these children who have the cognitive ability yet are not performing as well as their other non-Hispanic counterparts as they enter kindergarten. And why is that, and how can we join forces? And I have also seen the importance of community participatory action research, in which you join hands with the communities that you're working with to answer the questions that are not only important to you as a researcher, but important to them as a population. And so that I've gone backwards. I started out with the preschool children, and I've worked my way backwards, picking up with the previous speaker's age group once they are getting ready to start the preschool period during their toddler period, and the importance of not only working directly with the child, but also working with the parents. But I only mention that just to say that I have been looking at these areas from as a researcher for a number of years, because I'm so committed to making sure that things are going to change for the population that follows. So by 2050, as you can see, Hispanics will be 25% of the U.S. population. And I say that globally because Hispanics are Mexicans. I'm Mexican-American, the daughter of immigrants. We're Cuban. We're from Puerto Rico, and we're from different parts of Latin America. And you certainly see that microcosm as soon as you walk out this door, with the service workers that are actually providing the coffee, cleaning the bathrooms, and cleaning the streets outside here in Washington, D.C. And among Mexicans, the probability of returning after 3 years in the U.S. rose to 46%, 97 to 02. And the feminization of migration, with women remaining in larger numbers in the United States, is certainly a phenomena that has continued over time, is growing. The restriction on legal and social rights of immigrants has had no measurable impact on the flows, and the large backlogs and family reunification contribute to unauthorized migration, and this is from the Georgetown Institute for the Study of Migration. The leading causes, and I'm not going to spend much time with this, as has been said already: heart disease, cancer, accidents, cerebral vascular disease, diabetes, very much directly related to the obesity epidemic that's occurring among the Hispanic and other members of the population in the United States. Homicide, liver disease, respiratory disease, influenza, pneumonia, and problems during the perinatal period, as was earlier discussed. Lack of health insurance continues to be a growing problem for all of us, but especially with the Hispanic population. And as you can see, there was about 34% of Hispanics that were not covered not covered with insurance. And this statistic has not really changed significantly. If anything, it just continues to grow. 1 of 4 preschool children in the U.S. are Hispanic. They are the largest group of minority children in the United States. They compose 16% of the population under 18 years of age, and these children will account for significant proportions of future U.S. leaders, workers, and taxpayers that will be taking care of us as we age, as we are all going in that direction in this room. 1 out of 3 live in poverty. And already the statistics and the implications of that have been very well described by a number of the speakers. And the number of uninsured Latino children is greater than for any other racial ethnic group. And these children are most likely to have suboptimal health status. And we were talking about the epidemiological paradox, and that is true for the first 5 years. But something does happen after those 5 years which starts to significantly change these statistics. On the other hand, with the mental health of the parents, even before those 5 years are over, there is already published studies that indicate that there is a high incidence of depression, substance abuse, and anxiety among newly arrived Hispanic immigrants. Now, maybe this hasn't been reported in many of the healthcare settings, but frequently is because there's a lack of culturally competent healthcare for those that are able to access it. There's a higher risk for behavioral and developmental disorders. Frequently, it's because people really have not been taught in school how to correctly evaluate these children, and they are likelier to stay in those categories for a longer period of time during the school system. Puerto Rican children have among the highest national prevalence of developmental disorders and functional limitations. Research is needed to find out why. Many unanswered questions about the mental health needs and use of services by Latino children in general, and dental caries are disproportionately higher. There's a high risk for obesity, and with the in a consequence of diabetes. The boys seem to be more overweight. The girls are the second most overweight category of U.S. children. And again, more research is needed to determine why, and more research is needed to develop preventive intervention. And I want to again say that we really do need to do more in terms of this area, but not only in terms of the researchers gathering interest in this, but in terms of all of us here who are professors training the next group of researchers to be able to do that kind of research, not only with Hispanic children, but with all children that are vulnerable due to health disparities. More than 500,000 Latino children have asthma, and Puerto Rican children have the highest incidence, with 6% for black children and 3% for white children. Well, I won't go through this now. Okay, and then again, you see that a very high rate of children are not covered by insurance, with the largest proportion being Hispanic. And as the population grows, so does rates of the uninsured, which again diminishes their access to care. And everybody has mentioned immigration. Acculturation, years in the United States definitely have to be measured when you are doing research with this population, because it does make a difference. And obviously, having access to bilingual researchers is also another plus too. Okay, education. Hispanic children are less likely to participate in early childhood education for a number of reasons. First of all, the parents are less likely to interact in English, and also are very distrustful. And if they happen to be undocumented, they're even more distrustful. And Latino girls are less likely to participate in after-school activities, including sports, arts, scouts, religious activities. What does this mean for children? I mean, and not just for Latino girls, for Latino boys. What happens when you're applying for college? They're looking at all these extracurriculars, but these kids have been holding part-time jobs, oftentimes working all summer long to be able to afford the clothing that they're going to pay for to go to school in the fall. Okay, how do we increase access to this population? And here I wanted to very much look at the Sullivan Report. And access is not just having clinics available. Access is having physicians, nurses, dentists, public health officials, social workers, nutritionists, having access to all of them. And there's limited diverse faculty role models currently. 10% in baccalaureate graduate schools of nursing, 8.6 in dental schools, 4.2 in medical schools. And this is based on the Sullivan Report. Diversity is also related to disparities among health professionals. Again, there's fewer of us in line. And the rationale, therefore, for increasing diversity is compelling, not only to increase the numbers because we are facing severe shortages, but also to increase access, and also to increase researchers that will be able to carry and follow through on many of the areas that are being discussed here for the lifetime, continued through these projects. But there are historical roots of disparities at all levels of education and practice. It was earlier mentioned by Dr. Williams how racism continues, and it is alive and well in the healthcare professions. Underrepresented providers, and again here, this is just a little background. Black, Latino, and Native Americans are underrepresented among healthcare workers in the United States. And this just gives you some statistics that you will have access to. And then the American Association of Medical Colleges, they talked about the means for the MCATs and how applicants from underrepresented groups had lower scores as they were doing the application exams. Okay. Well, I've already mentioned this one. Okay, population by diversity, and again, I just want to say that if you look at the registered nursing workforce in the United States, 87% is Caucasian, and we're talking 2006, and these are numbers from the American Association of Colleges of Nursing. So when we talk about preparing children that are undergoing health disparities to be able to go on to school, these are the kids that need to be, this is an untapped resource that we really need to have a better job of pulling them in so that they can take the seats up at the front of the room. And this is just more about that. Okay, so healthcare systems must be built on access, quality, and cost effectiveness. Those are the three pillars of healthcare. And we've talked about them in general in a variety of ways today, but I really want to reinforce the fact that it is only by looking towards the next generation that we almost have a moral accountability for it, that we will start to be able to effectively attack that. Culture in the health professional schools must change to increase diversity. And I know I hope I'm speaking to the choir here, but it's a message that I say over and over again, and it's part of the reason I took the job I am in right now. We must develop new and non-traditional paths to health professional education. Health disparities is usually a small lecture in most of the health professional schools. It's very few that integrate it across programs. It's like a PS at the end of some of these major lecture series. It needs to be integrated throughout. Commitment must be made at the highest level of partnerships between academics, practitioners, and stakeholders. That means that the academics in the university ivory tower silos really do need to talk more closely with the practitioners out that are actually facing some of the problems that we were talking about earlier today, to really start to look at how we can creatively change curriculums to better serve the students so that they will actually be ready to go out and work in these communities. In some of the settings I've worked at, I've had nurse executives, tell me that if I had done a better job, and I'm talking about the schools I was teaching at, if I had done a better job as an academic professor, that they would not have to spend so much of their budgets on really preparing these new graduates to be able to work in these communities. So something is missing along the way so that we can have better use of the money that's available to train these students. Engaging professional and community coalitions to improve access, quality, and finance, including community health workers. We need to open the teams to realize that because there is a growing shortage of physicians and nurses and public health across the board, we are going to have to start developing partnerships with community health workers. This is being done in different ways in rural communities, and it's also starting to increase in urban communities because of this shortage. Obviously, from a public policy, we need flexible, comprehensive health policies. And there are many that are being circulated right now in Congress, but that have not been voted on yet. Changing the curriculum for the 21st century healthcare. And what that really means is that we have been heavily invested in acute care. But what we're talking about here is a long-term commitment to prevention and to chronic problems. And more needs to be emphasized in the curriculums in the healthcare professions along those lines. Interdisciplinary approaches to research on the elimination of health disparities, partnering through community participatory action research. What it really means is that all of us up here need to do a better job than we have done in the past to work together as a team to start to make some of these changes outside. So that means that the senior public health people work closely with the medical people, with the nursing people, with the dentists, so we can really effectively and in a cost-effective way start to make those changes happen. Binational cooperation to better manage migration between Mexico and the United States. I cannot tell you how important it is, especially in the area of immigration, be it African immigrants, Caribbean immigrants, Latin American immigrants, that we really need to work with the healthcare providers in those countries as they are coming back and forth for a couple of reasons. First of all, we've not done a very good job of teaching culturally competent care in our schools and training culturally competent researchers. They do have the keys in some of these areas. And so, it's almost out of respect, too, that they do have that kind of expertise, that we shouldn't have to reinvent the wheel. At the same time, they should understand the circumstances to which their people are migrating to. And somehow we need to partner with them to help to make it better and help to make it cheaply better. And obviously between workers and employers. And I used here health systems beyond the borders between the Department of Health and Human Services, health ministries, and for example, in Mexico, the Institute of Medicine for the Social Security arm that has both a civil service and an outreach program that they work with. Binational health insurance plans should also be something that can be considered in the coming years. New approaches in faculty and student exchange. It's very, very prestigious to have global exchanges, but to have global exchanges that are focused, that have a long-term trajectory and outcome for both sides is something that really needs to be more thoughtfully considered at this point in time. We need to improve the Spanish-speaking skills of United States school teachers and healthcare professionals. Every place else in the world, English is a language. I mean, in Mexico, many schools, not all schools, but many schools require, especially in the private schools, that a child by the time they hit kindergarten already has some basic level of English proficiency. We don't start doing that here until kids are in high school. And then also teaching English in Mexican schools is also a growing concern. As I have worked with healthcare professionals in Mexico, they are also having a problem with teaching Spanish as a second language, just like we have English as a second language, and they are not prepared to do that. So somehow we need to get together on this dilemma. Helping underrepresented populations gain admission to health professional schools, this is just an example. Reforming pre-college education to prepare a diverse student pipeline. And I use here as an example the Hispanic Engineering, Science, Technology, Education curriculum at the University of Texas Pan American. They do it once a year. They bring together the best and the brightest students that are doing exceptionally well in science and math. They emphasize engineering, science, and math. And I'm really starting to talk to them that the same skills are needed for medicine, nursing, dentistry, and public health. Magnet schools and evaluation of HRSA pipeline programs is also needed. There's a lot of money going to these programs, but what are the results? And the Robert Wood Johnson Foundation, there's a number of people here in this room that have talked about their own participation as a scholar, as a faculty member, what have you. I happen to be a fellow too. But they have offered very unique ways to really start to make a difference with comprehensive community coalitions that they have funded, Partners in Nursing Future addressing the shortage in nursing, especially of minority nurses, health policy fellowships to make changes in just the arenas we're talking about. These are my kids, and these are my families. Thank you.
Okay, thank you very much. Thanks to all our speakers. We've gone over on time, so no hard feelings if anyone has to take off. But I think we will take a few questions as well really quickly. If you could make them short and sweet, please. Over there on the side.
Hi, I just wanted to say thank you to all of the panelists. My name is Kaylon Taylor-Clark, and I'm from Harvard University and the Dana-Farber Cancer Institute. And I had a question for Dr. Braveman. Dr. Braveman, you said that potentially racially targeting some of these policies and programs would be one step to moving forward to bridging sort of the research into the policy arena. And national survey data from from National Election Studies, particularly around government's role, but other types of roles and resource allocation show that the general public has become less supportive of racially targeting programs, even though they're becoming more supportive of increasing spending on health care. And even among blacks, that's showing to also decrease over time, over the past 10 years. And I'm curious about how you would suggest a balance for that, or how you would suggest actually thinking about targeting some of these groups, but also getting some of the political and public will behind actually targeting some of those resources.
Okay, thank you. I think, is there a question over here as well? Up here in the front.
Yeah. Sorry. Hi, Nancy Breen from the National Cancer Institute. I just wanted to thank all of the speakers, including the earlier speakers, for what they had to say. And there were so many good policy ideas that were brought up today. And I just wanted to make the comment that I really hope that the Woodrow Wilson Center makes a point of getting these policy ideas to policymakers, because there are some of us from the federal government, like myself, in the room, but we don't have access to our policymakers, and I want to make that clear. And so it's really, there needs to be other ways to get this information to the Congress and to people so that they can start to think creatively. There's one other point I'd like to make, and that is that these great policy ideas, I think, are very hard to implement at the federal level or at the national level, as we call our federal government in the United States, and they're much easier to implement at place, at a particular place. For example, one of the efforts that we support is the California Health Interview Survey, and what they found in California, which has a sample about as large as the whole National Health Interview Survey does, is that by getting county estimates and bringing that to the attention of legislators and local organizations and advocacy groups, they're able to see where the problems are in their own communities and address those problems. And it's really starting to make a policy impact. And so I just wanted to put that out there as something that we might want to think about as a nation, to get better local data in order to be able to know what the local issues are and to address them on the local level, because that seems to be where the action is. Thank you.
Okay, I think let's take a shot at those two questions. Anyone who wants to?
Well, responding to the question about targeting of programs to blacks, it's a very good question. And I actually didn't mean, I felt even as I was saying it that I was misspeaking. I don't think that you can, at least openly, target to particular groups, but I think that what you can do, and in any case, I think that, what we need is policies that are going to at least reduce and preferably eliminate at some time the severe childhood economic adversity among all racial and ethnic groups. But I do think that unless there is an awareness of how implementation can, plans for implementation can very easily reflect the existing inequalities, and unless there's a systematic plan in mind for how you're going to overcome that, so that the people who are the most vulnerable are at least getting their fair share of the resources. That's a longer-winded way, but also more accurate way of saying what I meant.
Let me just add to that. I think the question really raises a dilemma, because I think unless we target, we will not reduce disparities. I really think so. If you look at the evidence of the last 100 years, health has improved. Health has improved for blacks. And you've had an overall improvement with the persistence of disparities. The only way you will reduce disparities is you have to have the disadvantage improve more rapidly than the rest of the population. So there is the need practically for some sort of targeted strategy. But you're absolutely correct. The data is overwhelming that the United States is population in general, public opinion data and survey research data is opposed to strategies for the poor in general, and even more opposed to strategies. When you frame the issue for blacks, there's even less support than if you frame it for the poor. So there isn't the political capital out there right now for race-targeted policies. I think that's clear. But it's also, at least to my mind, clear that we will not make progress if somehow policies are not targeted in a way that helps the disadvantaged to improve more rapidly. Else we will improve all, but still leave the gap. So I think it's a dilemma. It's one that I think we need to work with political scientists and others and spin doctors who can help us who can help us to package the issues in ways that resonate with fundamental American values, that we can galvanize support for them. I think right now the support isn't there in the general public.
I would add to that team an economist, because it's all about the money. And if you can make a case that this is a cost-effective way to address this issue, the economists really need to be pulled in.
Can I respond to that question?
Mm-hmm.
I mean, I think we're extraordinarily short-sighted in our I think we forget history very quickly in this country, and if you pardon a little gray-haired soliloquy here, the fact of the matter is that not long ago, 40 years ago, there were massive changes in this country, political changes, which were not based on everybody getting a piece of pie, which were not based on economic benefits, but which were based on social justice. From Michael Harrington through Martin Luther King Jr., through the War on Poverty, those were movements, strong social movements, which did a lot of things. They didn't stick. That was the problem. They did a lot of things by not appealing to a common economic interest, but by pointing out injustices, by pointing out that things were wrong. And I don't understand, and I've never heard any political scientist tell me, why it isn't possible to engage people, to have charismatic leaders engage people around the extent and depth of the unmet needs in this country.
Well, and I'd
More of a speech than a question.
Yeah, well, and I'd like to underscore that. I feel that we need to put a lot of effort into how we frame those arguments. I've done a lot of work with the World Health Organization in Geneva, and I remember when I first started doing any work there, it was this cultural shock, because I felt that I could talk about things in certain ways that I was forbidden from talking about them here. But in terms of the values, so a lot of values that sound radical now in the United States are very much mainstream public health values. And I sometimes I think that talking more about human rights and appealing to principles of human rights could be, that could be part of the path that we need to go down.
Let me just make one last point. I agree with George that we need to have a larger sense of optimism, and feel that we can make a difference. Part of the challenge that we need to walk out of this room with is we've been taught. Part of the problem is not the only part. It's more than that. Is that most Americans are unaware that disparities even exist. That's what national polling data shows, that most blacks, most whites, most Latinos are unaware that racial disparities exist in health. If there isn't a problem, if you don't perceive a problem, there's no need to mobilize to address it. So that just even raising awareness levels of the magnitude of the disparities that we're talking about, and they're quite stark, I think throughout all of the presentations today, is something that we shouldn't assume that most American adults are unaware that these disparities exist. So first we have to raise awareness levels, and I agree with you, create a vision of what we want our society to be like in the future, and get people to commit to that.
Okay, well.